I am Adrienne Windsor. I'm a member of the board of the Newport Beach Public Library Foundation, and this is a program that is sponsored jointly by the foundation and UCI Health. So we are very fortunate to have this program, which is sponsored by Mike and Polly Smith, who have been our sponsors since the very beginning of it. I also want to thank Kunga and Jane. They've been organizing this program for us for years, and we've come through a very wonderful, successful season, and they have done a tremendous amount of work for us. So please give them a hand of appreciation. Now, a quick bit about us. Our foundation is a membership foundation. We sponsor all kinds of programs. How many of you have been to our Library Live or Witty Lectures? Quite a number of you. We also have Spotlight on Science, we have literacy, we have the book discussion group, we have finance workshops. All of these are sponsored by the foundation, and we are membership driven. How many are members? Well, I'm going to give you a big pitch to see if I can encourage you to become a member before the end of this month. In fact, by tonight or tomorrow. On June 18th, we're having a summer solstice. It's a celebration of our new members. And we have wine and hors d'oeuvres and special desserts. And this year we're going to be right out here, outside the community room. We are bringing Michael Hilslick from the LA Times, who's written a new book on California, the Golden State. He'll be our speaker. So if you want to become part of this community, want to become part of this foundation, I urge you to join. The lowest price membership is only $50, and you'd get a whole evening out. So please do that, and please show your appreciation for our programming by becoming a member. Okay, so a little work here. We'll save our Q&A until the end. And let's remember that these are on YouTube and on our website, so we want to refrain from giving our own personal medical histories when we ask our questions. Also, if you haven't silenced your phones, would you please do that right now? All right, so our speakers tonight are Dr. Janellen Smith and Dr. Jessica Shiu. And Dr. Shiu is a board-certified, she'll be the first one, UCI Health dermatologist who specializes in, she told me how to pronounce this, vitiligo, inflammatory skin disorders, skin cancers, and melanocytic neoplasms. She says moles. I think we can all relate to that. Dr. Shiu earned a medical degree and a PhD at the University of Maryland School of Medicine's Medical Scientist Training Program in Baltimore. She completed an internal medicine internship at the University of Maryland School of Medicine, followed by a residency in dermatology at the UCI School of Medicine. She must have done very well because they kept her. Dr. Smith is board-certified UCI Health dermatologist who specializes in skin cancer and melanoma. How many of you in here tonight have had melanoma? Okay, I'm not surprised. She obtained her medical degree from the University of Iowa, completed her residency at the University of Michigan Hospitals, where my son was born. So I was real pleased to hear that she spent some time in Ann Arbor. Dr. Smith is a professor at the Department of Dermatology at UCI School of Medicine and co-director of the Pigmented Lesion Program. So please join me in welcoming Dr. Shiu. She will be our first speaker.
That way I don't have to just stand behind the podium and can see all your faces. So thank you for that introduction. I'm Dr. Shiu, and so today I'm going to start by going over some common skin growths that we see as we age, and when do we need to worry about skin cancers. In terms of disclosures, I am an investigator for AbbVie for some of my vitiligo studies, but nothing relevant to this lecture. And so today it's a two-part talk. I will be introducing the skin and what we look for as dermatologists to all of you, and start talking about some common skin growths that we see as we age. And then I will cover some of the non-melanoma skin cancers that many of you may be familiar with, such as basal skin cancer and squamous cell skin cancer. And then Dr. Smith, we'll switch over to Dr. Smith, and she will talk more about melanoma and then also just overall skin cancer prevention strategies. So, you know, a lot of people maybe don't know this or totally underestimate our skin, but the skin is actually the body's largest organ, and it carries a lot of important functions. First of all, we don't think about this all the time, but we are constantly challenged by bacteria and viruses in the environment, and our skin normally does a really good job at protecting us from infections. It also helps us regulate body temperature so that when it's hot, we start sweating, and keeps us cool. And then, of course, our skin enables us to touch and have tactile sensations. And so sometimes after you have skin surgery, those sensations can be a little changed, and your sensation, the feeling, you know, can change a little bit. And so did you know that the average adult has 20 to 22 square feet of skin, and it accounts for almost 10 to 15% of your body weight? So if you want to lose some weight, maybe we need to lose some skin. But really, you know, to really understand what our skin does and where skin cancer comes from, we need to first understand what our skin does. And so when we look at our skin as dermatologists, we think about skin in 3 different layers. You know, there's the top layer that we commonly see, which is what we call the epidermis. And then in the middle is the dermis, and that's where all your collagen, your blood vessels, and things like that are located. And then there's the subcutaneous tissue where there's some fat, and then the muscle layer is right underneath there. In this diagram, it looks like it can be quite thick, but really depending on the body location, so like the face or the neck, you know, it can be quite thin. So you can get to the muscle layer really quickly. And so the epidermis is the surface layer, you know, that communicates with the outside environment, and it helps to prevent germs from entering our skin. And it also provides color, you know, to our skin. So we don't think about this, but most of us have a lot of even skin tone, you know, and that's like there's turnover every day going on in your skin to help maintain that color and tone. And then, as I mentioned, in the middle, that's where your collagen and your elastin is housed, you know, and also your blood vessels and your hair follicles, you know, are also kind of in the middle layer, as well as sweat glands. And those are all things that can change with temperature and also as we get older, which I will kind of go into a little bit more detail. Then, you know, when we think about why our skin ages, you know, we know from a lot of studies that actually our collagen production stops around, like, once we hit our 20s. It really starts declining. And so by your 40s, the collagen production is almost done already for the rest of your life. And so our renewal capacity, you know, really decreases as we kind of even just enter adulthood, you know, that's the process is already starting. And so as we get older, there's loss of fat, there's also loss of bone mass. And then as we live, right, we also have a lot of exposures, so we live in Southern California where we're close to the beach. There's sun exposure, there's environmental exposure, like to smoking. We also know that smoking can age your skin. And then also just things that are in the environment. When there were wildfires, for example, we would see patients that were more irritated because that's the type of chemicals and toxins that could come in contact with your skin. And so what that means is that over time, the top of the epidermis really kind of starts thinning, their reproductive capacity is lower. And then the dermis layer, where your collagen and your blood vessels are, really start to shrink, And so the collagen normally provides a cushion, for your skin. And as we get older, that cushion is gone. And what that means is that you don't really need to do much to get a bruise. You can just rub against this little thing and you can end up with a pretty significant bruise on your forearms. And the reason why we most often see it on your forearms is that's an area that sees a lot of sun, over time and tends to thin quite dramatically in terms of the collagen and the cushion layer. Other than the easy bruising, we also see with cumulative sun exposure the development of sunspots, which I think most of us are familiar with. I have some myself. And then also, our skin tends to be more dry as we get older, so because there's less oil production. And so overall, it's easier to be itchy and be sensitive to other things. And so, this is just a very famous picture in our dermatology field that illustrates the power of sun exposure, So this is a truck driver for 30 years who was getting a lot of sun to the left side of his face. It's noteworthy that windows, just regular car windows, do not prevent UVA penetration. And so you can still get aging of the skin. And so you can see on this gentleman that there's significantly more signs of aging on the left side compared to the right. Just try to see if this pointer will work. But I think you can appreciate that there's a lot more wrinkles on the side over here, and just, more volume loss as well. And so, other than thinning our kind of cushion layer in our skin, sun exposure can also lead to the development of these benign spots that a lot of us have, that we commonly either call sunspots or some people call them liver spots. And so they're usually on sun-exposed areas, kind of like your hands or your face even. And they're actually completely benign, but they can be confused with something that's a little bit more worrisome, just because of the color that they have. They're a little brown, and sometimes over time they can get a little darker, making it a little confusing when we're looking for melanomas. And that's usually, a reason why you go see a dermatologist, is so we can tell which one's benign and which one's not. And so now I'm going to go over some other common benign skin growths that we see with aging, and maybe many of them that you'll be familiar with. And so one of the most common ones we see, in the clinic is something called seborrheic keratosis. More commonly, I think people refer them to as barnacles or keratoses, and they can grow anywhere on the body. And we know that they tend to increase with age. So, you can start initially with just 10 or 15 on the body, and then we have some patients where their back have like 40 or 50 of these barnacles. But they are benign, but, I like to say that they're very annoying and they kind of have a mind of their own, because they can get a little thicker, They can get a little darker, they can change it a little bit. You can pick them off and then they grow back pretty quickly. And so there are all signs, that would normally make you a little worried, but the main reason why we do not worry about these being melanomas is that they come from completely different cell origins, so melanomas come from our cells that make pigment and produce skin color, whereas these seborrheic keratoses come from a different member in the skin. So they don't have any malignant potential, but they can be confusing and difficult to differentiate. And even sometimes for dermatologists, it can be a little tricky. And so sometimes we'll recommend a biopsy if we're not sure. Some other common benign skin growths that we see are these little red dots, that start growing very commonly on the trunk, on the belly area, but they can really be anywhere. And they look like little cherries. I think if you look at the picture, you can appreciate why we call them cherries. But when we look at them under the microscope, they're little benign growths of blood vessels, that also, again, don't have any malignant potential. But these guys can bleed a little more, if you scratch them, just because they're connected to a blood vessel underneath. You can really get a little bit more bleeding associated with it, and again, just is annoying to have. And then and then we also have skin tags, that are very common at sites of friction, so meaning most commonly usually around the collar, for where your clothes rub against your skin. Sometimes we will see it under your armpit or kind of the inner thigh area where it rubs against the skin, and also under the breast, very commonly for women. But again, these are benign. And then finally, there's moles, which are kind of the cousin of melanoma, which Dr. Smith will go more into. And these are the ones that can look quite different, but they tend to be brown. Some of your moles come very early. Some people have moles since birth, whereas some other people can have moles that grow a little later in life. But generally, before their 40s, all your moles are done growing. And so these can also have a slightly different appearance. Again, they can be brown. So that's kind of the challenge, as you can see, is that we see a lot of things that are brown, and so our job is to differentiate what is benign and what is malignant. And so, these moles are generally, also benign, but these are the cousins of melanoma. So these are the ones that if they change, we do worry about them being a skin cancer, and what Dr. Smith will go more into. And so now we'll switch gears a little bit and talk about kind of lesions that we start worrying about, that we categorize as skin cancers, but not as melanomas. And so most commonly, these are basal cell carcinomas and squamous cell carcinomas. So, when should we worry? Generally, they present as like rough, scaly red patches, but that's very nonspecific, right? Like a lot of times we have rough, scaly red patches from using maybe a new soap or a new product, but the thing about these is that they don't tend to go away. They hang around for months, for more than 4 to 6 weeks, and then they start crusting. They tend to bleed, even if you put a Band-Aid over them, they start to bleed, and you have to constantly change the Band-Aid. Sometimes they can be rapidly growing, and I think most of you in this room, if they're rapidly growing, you're concerned. That's generally a sign that people know to be concerned about. And then also, if they're kind of open sores and just oozing and never really heal. Those are all signs that we should kind of prompt you to go maybe see a dermatologist. And then again, the changing brown and irregular spots, especially for a mole that you've had a long time that suddenly starts changing. And then one of the signs we like to say in dermatology is the ugly duckling sign, where you have a spot that just looks different from everything else, That, again, is a sign, can be a sign of skin cancer and something that we watch out for, and certainly something that you should seek care for. And so basal cell skin cancer is one of the most common skin cancers that we see, and we know that it's associated with sun exposure. The good thing about basal skin cancer is that they tend to grow just locally, but they don't tend to spread. But they can present looking like initially like a little bump, that you're maybe not worried about, but then over time it starts to grow and starts to crust or bleed. And so they can really look many different ways. I think that's the hard thing about basal cell skin cancer. So they can look like a pearly nodule here on the left, and then to something that's more kind of pigmented in the middle with a little bit of color change. And then on the nose, on the right here, it can almost look like a scar, with an indent. So it doesn't always have to be a raised bump. It can even just be a little indentation that kind of keeps bleeding and crusting over. And so, usually when you come see one of us in the dermatology clinic and there's a spot that you're worried about or we're worried about, we would do something called a biopsy to confirm the diagnosis. And so usually a biopsy, what it entails is just a very tiny needle, like of lidocaine, kind of like when you go to the dentist. That's injected into the area, and then there's a very small piece taken, and you'll have a tiny scar from the biopsy. Some people don't end up with a scar, but most of the time there's a little tiny scar, and then we send that specimen to the lab to get a definitive diagnosis. And depending on what the diagnosis from the lab says, we have different ways we can treat basal cell skin cancer. And so the goal of treatment is always to ensure that there's no cancer left, but that can be achieved in many different ways. So it really kind of depends on some of the features of the basal cell skin cancer. If it's just on the very top layer of your skin, you can actually just use a cream. You don't need any type of other invasive procedure. And that's because it's only on that top layer of the epidermis that's in contact with the environment. And the cream can penetrate that really well. And that alone can be enough to get rid of the skin cancer. But then for some of our deeper basal cell skin cancers, there are other options like doing scraping and burning, and then there's surgery where we cut the whole thing out, and then finally there's also Mohs surgery, which maybe some of you are already familiar with, but essentially I'm going to go into this in a little bit more detail, but the goal of Mohs surgery is to take as little skin as possible while getting rid of the cancer. And so all of these different options really kind of depends on the type of basal cell skin cancer that you have, how deep the skin cancer is, and then what your kind of risk-benefit profile as a patient is. So a lot of times this is a joint decision that we make as physicians with our patients. Because they have different recurrence rates. That we will explain. Depending on the type of treatment that you select. And so this is just a little diagram showing what Mohs surgery entails, and so as I mentioned, the goal is to remove the whole tumor while taking the least amount of skin as possible. So what that means usually is that you're in the clinic for the whole morning or the whole afternoon, half a day. And so the reason why you have to stay there is when they take a little piece, the first time they put it under the microscope, and they look at it right then and there, and so they can say, oh, look, I see normal skin from 12 o'clock to 6 o'clock, but there's a little bit of skin cancer left from 6 o'clock to 9 o'clock. So then they go back to the initial site, and they only take more tissue from 6 o'clock to 9 o'clock while leaving the rest of your skin alone. And so because of this process, it takes a little longer for us to process and read the slide in real time. So it can take a little bit longer, but the nice thing is that you end up with a smaller scar most of the time, or just if it's on a very sensitive area, we take as little as possible to kind of take care of the skin cancer, but hopefully have a nice looking scar afterwards. Although, of course, I have to say we do have some cases where the cancers can get pretty big and you can end up with a pretty big scar. So the second skin cancer I'll go over is something called squamous cell carcinoma, which we can also call it squamous cell skin cancer. It's the second most common skin cancer that we see after basal cell, and it is also associated with sun exposure, but it can also be associated with certain strains of a virus called human papillomavirus, the HPV, which you might be more familiar with in terms of like cervical cancer. You know, that's the virus that there's a vaccine for called Gardasil. But we do see some of these virus infections that can affect this type of skin cancer development, especially when our patients are immunosuppressed. You know, whether you're on an immunosuppressive medication for like an autoimmune condition or an organ transplant or some other infections like HIV. And these, you know, are important for us to catch because these can be a little bit more aggressive, especially when they're in the head and neck area, and they can have the ability to spread. And so I just included some pictures of the different phases of squamous cell skin cancer. As you can see, they can look very kind of benign, like a little scaly patch here on the left. Sometimes we see them like looking like a little horn, like here on the bottom middle that you can see. We call it a cutaneous horn, actually, but that can also be a sign of skin cancer. And then sometimes you can see more obvious signs where it is, you know, growing very rapidly or expanding very quickly. They can also happen in sites of chronic wounds, you know, so if you had a diabetic ulcer that's there for a long time, sometimes we would take a biopsy if there were things changing, you know, about it, just to make sure that there's not a little skin cancer growing. And so actually the treatment for squamous cell skin cancer is very similar to basal cell skin cancer and really depends on what the biopsy shows in terms of how deep and what type it is. With the squamous cell skin cancer, we really sometimes will grade it in terms of whether it's aggressive or non-aggressive when we look at it under the microscope, and that helps us to manage the risk and what we do and recommend for treatment. But again, if it's just on the very top layer of the skin and on a low-risk site, like your arms and your legs, we can just recommend a cream, and that's all you would need. But then you can also go into the more aggressive or more kind of extensive treatment options like Mohs surgery or surgery, and then again, the scraping and burning that we do in clinic. And so just to summarize my part of this talk, there are some key points, you know, for all of you to remember is that bumps and growths, you know, happen a lot as we get older. But when do we worry about them is when they don't fully heal after 4 to 6 weeks and they keep bleeding on their own. The diagnosis of these skin cancers normally involve a little skin biopsy, and then the treatment type can really range from like a topical cream to more extensive surgery, depending on the depth of the skin cancer and the type of skin cancer. Great.
Yay. All right, part 2, melanoma. She has talked about the 2 most common types of skin cancer. This is the least common type of skin cancer, but it's the most deadly. So this is something we really want to catch early. See if it works. Oh, good, it works. So if you look at cancers overall in the body, they're the top 5. Both include melanoma. So men and women, one of the top 5 skin cancer, cancers overall. In 2025, we predict that there will be 212,200 melanomas diagnosed and approximately 105,000 invasive. We'll talk about what invasive means later. It's most common in men. There will also be 8,430 deaths, again, more common in men. So that was the bad news. The good news is that about 10, 15 years ago now, some new drugs were discovered. And in 2011, the first one was okayed by the FDA. It was called ipilimumab, or the other name for it was Yervoy. And before that, we had nothing really to treat melanomas when they had escaped other places in the body. But this has been a game changer. So if you look from 1986 to 2013, the number of deaths from melanoma amongst whites was 7.5%. From 2013 to 2016, it fell by almost 18%, and that is because of those new drugs. If you look at who gets melanoma, it is, let me see if this works. No, oh, it does, okay, sort of. If you look at who gets melanoma, it's mostly Caucasians, but we do see it in Hispanics and other ethnicities. Hispanics are the #1 increasing group of people, so we're really watching them carefully right now. Interestingly, if you look at Caucasians versus African Americans, Caucasians are 20 times more likely to be diagnosed with skin cancer than African Americans, but the 5-year survival in Caucasians is 94%, and it's only 69% in African Americans. African Americans are 4 times more likely to receive a diagnosis of melanoma after the cancer has progressed to an advanced stage or spread to other parts of the body. So we gotta do better with that. So. What about the sexes? So if you are under 49, we might have a few of those here. If you're under 49, then women have a higher risk for melanoma. Above 50, it's more apt to happen in males. If you're younger than 50, the incidence of melanomas has stabilized in women and decreased 1% in men, so that's a good thing. Older than 50, the incidence of melanomas has stabilized in men, but has increased by 1% in women. It's not a lot, but it's enough that's significant. So the 5-year survival, what that means is if you had 100 people with melanoma, how many would still be alive in 5 years? And the answer is 93.5%. In 1950, when I was born, the survival rate was 50%. So we've really come a long way with that. I kind of like this. Oh, I can't even show you. That little guy there that's only half. I'd like to meet him sometime. He's kind of cool. And what countries do you see more melanoma in? Well, by far, New Zealand and Australia are right up there. And in fact, USA is a little bit down. Doesn't mean we don't have a lot of melanomas. But again, that's where we see the most. Why? Well, they have a very outdoor lifestyle. They're closer to the equator than we are, so they get a more significant sun. And the ozone is not so good in those areas. So the ozone around Australia is getting worse over time. So if you go into my office, how do I tell whether you're at high risk for melanoma? Well, there's 2 things we look at. We look at host risk factors, and we look at environmental risk factors. When we talk about host, that means you guys. So I say, okay, what's their skin type? So if it's very pale, that somebody's going to be at higher risk. We talked about age and gender. We also look at the number of moles. If you have 100 moles or more on your body, your chance of getting melanoma is higher. If you have a personal history of basal cells or squamous cells that Dr. Shiu talked about, then your risk of melanoma is higher. Personal and family history of melanoma, and immunosuppression. So that would be somebody like a kidney transplant, or someone with HIV, or somebody who is getting chemo. So those are the sorts of things we look at to decide how much risk. So this little guy, he's going to have a higher risk. We need to keep him out of the sun. And then here's somebody with oodles and oodles of moles, and basal cell and squamous cell. So we look for those sorts of things to decide the risk. How about environmental risk factors? Well, ultraviolet radiation is #1. So sunshine and tanning beds, so we'll talk about both of those. The other thing that seems to be happening is air pollution seems to be contributing to it. And as Dr. Shiu said, it was not very nice when we had all our fires and that sort of thing. That probably wasn't good. So ultraviolet light, it is a risk factor for all the different types of skin cancer. 1 blistering burn during childhood can almost double the rate of skin cancer. More than 5 blistering burns before the age of 20 can increase melanoma risk by 80% and basal and squamous cells by 69%. So not good. So 86% of melanomas can be attributed to ultraviolet radiation from the sun. But what else? Tanning beds. So you're going to hear us tonight. We don't like tanning beds at all. So there is no safe tan. Tanning beds emit up to 12 times as much UVA than the sun. So you can see why they might be worse. So this is a study looking at lots of different studies, and they say, we show that the number of skin cancer cases due to indoor tanning is higher than the number of lung cancer cases due to smoking. So we're very negative. And this is a little bit busy, but what it shows you, if I can point, maybe I can, is the more tanning you do, the more apt you are to get melanoma. And I didn't realize this, but there are many different types of tanning beds. There's the conventional one, which I think we all kind of think of. There's sun laps that people use at home. But now there are high intensity and high pressure. Those are the worst. Those are the ones that really increase your risk of melanoma. So risk is highest for those exposed at a young age. 1 in 5 adolescents and 59% of college students have been exposed to tanning beds. So children, grandchildren, those guys, they need to have a talking to. So women younger than 30 are 6 times more likely to develop melanoma if they tan indoors. The International Agency of Research on Cancer has a system where they rate carcinogens. So there's group 1, group 2, group 3. Group 1 are the worst, and tanning beds are group 1. What else is a group 1? Plutonium and cigarettes. So plutonium, cigarettes, and tanning beds. So I don't like to harp on it too much, but as you can see, this is something we don't like at all. Okay. But even without tanning beds, our Southern California lifestyle has been increasing our melanoma risk. How do I know, or how do you know whether you have a melanoma? Well, these are the ABCDEs of melanoma, and they're a little simplistic, but they're helpful. A is for asymmetry, so if you have a mole and you cut it like a pizza, and those 4 pieces do not match, that's a possible melanoma. Of course, none of these are a definite melanoma. Border irregular, so if you've got an irregular border, that can be a problem. Do not look in your magnifying mirror. All magnifying mirrors, or all moles in magnifying mirrors are irregular along the border, so ignore that. Colors, so a lot of colors can indicate a melanoma. Diameter, 6 millimeters, that's the size of a pencil eraser. Now, it doesn't mean that less than 6 millimeters can't be a melanoma, so if something suddenly changes or turns very black or something like that, and it's less than that, you still need to do something. And then my favorite, of course, is evolution, and what that means is you've got a mole and it changes, then somebody needs to see that. Or you have some place that never had a mole and it suddenly has a mole. That needs to be looked at as well, okay? So new moles. This is an ugly duckling. That's the other way we talk about it. So if you have 50 moles and one of them just starts looking really weird and none of the others, that's called an ugly duckling. And an ugly duckling is any mole that doesn't look like the rest of the moles on your body, and that's something somebody should look at. So where do they occur? In women, the most common spot is the legs. This is hard to hold, sorry guys. And in men, it's the trunk. Now, it doesn't mean it doesn't happen anywhere else, but those are the most common spots. And how do we talk about melanomas? Well, there are a lot of different types of melanomas, but the 4 most common are superficial spreading, so they start in one place and they move out. Nodular, which makes a big lump. Lentigo maligna melanoma, those are often on the face after lots of sunshine. And then acrolentiginous melanomas, hands and feet. Okay? So superficial spreading, I think you can see here that if you did a pizza on this one, that none of those 4 pieces will look alike. So this is a melanoma. This is another melanoma. Sometimes what you'll see is they'll lose some of their pigment centrally like that. And I think you can see that especially the colors are asymmetric here. So asymmetry, boom, somebody needs to see it. It's funny because you showed this as a normal nevus. And so maybe it is. But the reason I put it in here is because one of the things we look for is this sort of roughness over the top. So let's say you have a whole bunch of moles and they all look kind of smooth and cool, and one of them gets rough or scaly or something like that. That's something we watch for as well. This is one of the nodular melanomas. So they come up as a big lump. This is a guy I just saw this week. So he had a nodular melanoma. Sometimes they're pink. So if you get a nodule and it's pink, somebody needs to see that as well. You can see here that it's trying to make a little bit of pigment. And then sometimes you kind of have a combo. So you get a superficial spreading and it develops a nodule. That's actually not a very good sign. So we don't want that to happen. Lenticle maligna, those are the ones on your face. These are tough. These are tough for us. Tough for her, tough for me, because everybody has a lot of little brown spots on their face. So how do you tell one brown spot from another? It's not easy, but we'll go over a little bit of that later. But certainly if something is changing over time, especially getting darker, someone should at least take a look. There's another one, and you can see they're kind of asymmetric as well. And then one on the nose. Acrolentiginous, again, feet and hands, most often feet. Now, who looks at their bottom of their feet? I mean, I do now, and you guys will now, but acrolentiginous is kind of a bad type of melanoma. And you might say, well, why didn't this person come in sooner? But really, we just don't look. So good idea to look. There's one. And there's one. So all not very nice melanomas. And again, they just tend to be a little bit more aggressive. There's something called melanoma striata. Melanoma just means something pigmented. Striata means a stripe. So you can get melanomas under your fingernails. Honestly, you can also get nevi, or moles, under your fingernails. So it's not always bad. But if you have something like this, somebody should look at it and tell you whether it's something to worry about. Here's another one. One of the things we actually look for is this guy. Sorry. See how the pigment is coming back onto what we call the proximal nail fold. That's called Hutchinson's sign, and that can be a problem. It can also extend up the top of the nail, boom, onto the tip of the finger as well. So you get that sort of thing. That's not a good sign. And here we go. This is not him, but Bob Marley had one like this. Bob decided he was going to do alternative medications to begin with. He did, and he probably shouldn't have, because it probably could have been cured. But we like to see you guys right from the beginning. You can get them in the mouth. There is something called physiologic pigmentation, which some people have, particularly African Americans, where you get pigment that what we call respect the mucogingival line. So that's respecting it. But over here, it is not respecting it at all. It's going way up like that. That one's a melanoma, not physiologic. So you go to see the dermatologist, and they're going to look around and see if you have a melanoma. And the funny thing about this picture is, see that melanoma there? That's the same picture as what we saw earlier for superficial spreading. So somebody must have just taken it, made it really small, and put it on this lady. So if you go to a dermatologist, almost everybody now uses something called a dermatoscope, and it's basically just a fancy magnifying glass that you charge us a whole lot of money for, but we all have one, okay? Anyway, and so what do we use that for? Well, we put it down on the skin and look around and see what we see. If it's a normal mole, it has this nice network pattern, we call it. Very even, whatever. Again, we've magnified it here so that the edges are a little bit irregular, but we're not worried about that. This looks really good. But what if it's a melanoma, okay? We see something completely different. So there's a lot of things going on here. This is called a milky white change. There's some blood vessels here that are all whatever. But my favorite thing here is the pseudopods, which means fake feet. So fake feet, not a good thing. Oopsie, go back. Oh, can I go back? Let's try. Oh, yeah, okay. So remember we talked about invasive before. So if you have a melanoma and it is completely in that epidermis that she talked about, that is non-invasive. That's the way we want to catch them. We want to catch them before they go down into the second layer of skin. So this is beginning to go into the second layer. More, more, more. We definitely want to catch them before they get there. And when we say, oh, I think it might be a melanoma, or we get a biopsy back that says it's a melanoma, then we do what we call a margin. So basically a safety margin around it. And it's usually either 1 centimeter or 2 centimeters. So that's where you dry the circle. And then you do something called an ellipse around that. And that's how you take out the melanoma. So it's often a very big scar. If it's very deep, then we do something called a sentinel lymph node biopsy. You are injected with both a radioactive liquid and a blue dye, and then they follow it, boom, 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 and they see which nodes does it go into first. And those are called your sentinel nodes. It's like the sentinel out in front of the castle, right? And you take out those sentinel nodes, and they sew you back up, and they look at them under the microscope. If there is melanoma there, that's one thing. If there's no melanoma there, that's a good thing, right? So different outcomes for that. And we won't go too much into all that, but that is something you might get. So how do you prevent yourself from getting melanoma? So sunscreens, protective clothing, and sun avoidance. So let's talk about those. So sunscreens come in two varieties. One is called a chemical absorber, and the other is a physical block. They also are called organic and inorganic, but mostly we call them chemical and physical. So physical sunscreens sit on top of the skin, and the sun bounces off of them. So that's kind of a good thing. Chemical sunscreens actually sort of interpolate themselves in your skin there, and when the sun comes down, there's a chemical reaction. It makes heat, and the heat is dissipated in different ways, and that's how that type works. So if you go to the drugstore and you say, okay, what kind of sunscreen should I get? There should be a couple things you definitely have. One is you should have an SPF, or sun protection factor, of at least 30. A lot of my melanoma patients, I make them do at least 50. It has to be broad spectrum, and it'll say that actually on the bottle, all right? So it'll say SPF 30 broad spectrum, and that means it covers UVA and UVB. And then water resistant. Not always important, but obviously a lot of people do water sports here and stuff like that. Now, having said that, if you go into the water and you're in there for 10 minutes or something like that, it's probably a good idea to just put the sunscreen back on anyway. But it's nice to know that there is some water resistance. So here is a famous lady, a tennis player, and she likes the physical block. And back in the day when she was doing this, we didn't have physical blocks that looked very good. So when you put them on, they were white, like this. Nobody wanted to wear them. Now they are micronized, and the micronized variety is much easier to put on, and it looks better. So got a lot better ones there. Here, this little guy wants to show you his nice rash guard. So my kids wear rash guards up until 16, and I don't know why, but each one 16, boom, it was gone. They would not wear it after 16, but just to be able to get that many years was a good thing. Hats. So the bigger the brim, the better the hat. So there's a hat, and there's a hat, right? You can also use ones that have little flaps and this and whatever. This is called a gaiter, and that's a good thing to keep the sun off. So my favorite sunscreen is clothing, right? So I like clothing. Obviously, sunscreens are out there as well, but clothing is great. This is my dog, and he's showing you that he can be cool. And, oh, it's a she, sorry, honey. But sunglasses are a good thing as well. Sun avoidance. So limit sun exposure between 10 and 4, seek shade, and reverse your schedule. What does that mean? So if you're somebody who walks the beach during the day and goes to a movie at night, turn it around. Go to movies during the day, much cheaper, and go walk the beach late afternoon, early evening, okay? And of course, avoid tanning beds. These are my girls, and as I said, I kept them in rash guards till 16, so they did pretty well over time, but if you do these things, they can do well. So that's that, and I think we have question and answers.
Thank you. So maybe Dr. Shiu and Dr. Smith, you could come up here to this microphone, and I will go into the audience. We only have one handheld microphone tonight, so we'll have to switch this around. There's somebody back here's first, but.
Hi, how are you? I have a quick question with regards to non-invasive melanoma where you have it cut out and then it ends up being in situ and it is expanded out more than an inch from the margins. How do you deal with that? Are you using a cream? How far does it expand out? How do you know? And how much cutting would you do? And would you use Mohs for that or not?
Well, good question. There are places in the United States where they do Mohs for those. We actually do something called slow Mohs for those, and that just means it's not in one day, it's over multiple days that they do it. You know, we use histopathology, that is looking under the microscope to see what we see. Oftentimes when they are thin and they spread out that much, it's not a bad sign. It means that they're not really very aggressive in going down in, so we kind of like that. But you're right, sometimes they can be quite big. Do we use creams? Sometimes after somebody has slow Mohs with one of our surgeons, I will use something called omequimod, which she showed up there. The other name for it is Aldera. And basically what we're trying to do is, if there's anything left behind, we're trying to scoop it up with that cream.
You had a question?
Yeah. You touched on blue light therapy. Could you explain that a little bit?
Yeah, so blue light therapy essentially is done in the clinic, so you come in, usually if you have a skin cancer or we also do it for if you have a lot of precancerous lesions, that we call actinic keratosis, and that's a nice way to clean them up all at once. So you would come into the clinic, they would put a medication on, and then you sit in front of this blue light, and then afterwards, after the treatment, you would get some redness. It can get pretty red sometimes depending on how big and how many of these spots that you have, but that's kind of the idea, is that instead of using a cream at home and having to apply, maybe it's at a hard to reach area, you can go into the clinic and they can do this treatment without you having to deal with application daily.
Also, whatever happened to percussion? There was a very expensive drug.
Oh, no.
It was a topical.
No, that's not quite the right name. It was Picato. You say Picato, I say Picato, but that was the name. And I think that people didn't use it so much, and so it was probably a money thing that it disappeared, but some of my patients loved it. Some of them still have a few samples that they keep just in case.
I used the weed that is from, and it's very effective.
The weed?
Yeah.
You mean?
No.
No, okay. Okay. So you get it from the garden, and then you just, okay, interesting. Now there is something out there which people refer to as eggplant something or other. I would not recommend that one. It has something in it called zinc chloride, and I've had a few people come in with huge holes. In fact, the last guy, huge hole. And I said, "Oh, I wish you'd come in and let me do something about that." And he goes, "Oh, but Dr. Smith, it's gone." Yeah, it was gone.
And we have a question over here.
Dr. Shiu, you mentioned blisters, and you mean from the sun?
Yeah.
And I knew a kid in junior guards who did that, but I was in a boat and had scars after the boat blew up. And I don't have any cancer there on my legs, but I did in my ear
Yes. So
recently,
when we
which I
see
think was
blistering,
squamish.
we're thinking more like sunburn type of blistering. Certainly you can get blisters from like an injury, or even like certain autoimmune conditions can give you blisters, but those don't have any association with skin cancer.
But I would say, if you had some burns from a boat, when people get squamous cells in burns, even if it was like when you were a 2-year-old and you got burnt by a kettle or something like that, if you get a squamous cell in that, it's much more aggressive. So burn scars, sore, in to see the dermatologist.
Well, my mean mother made me wear long sleeve shirts the summer after.
Good.
So again, I'm talking about more thermal burns and stuff like that, yeah.
I have a friend who had melanoma on his ear. They got it, the margins were clear, and 9 years later he got stomach cancer, and they said the origin was melanoma, was that melanoma. How much of an incident is that, and can anything be detected prior to it developing in that horrible way?
Very good question. We have for years tried to find a blood test which tells us if there's anything that escaped before, right? So yes, they went and the margins were clear and stuff like that, but probably what happened is a little bit snuck off somewhere and was just sitting there for a time when they were stressed or something like that, and then decided to grow. So we would love to have a blood test that can tell us that in people, but I've been doing this for 40 years, and they've wanted a blood test for 40 years, and they've never found one.
Well, one of the issues that happens to so many people at an advanced age, especially in the female population, is the discussion of osteoporosis. And there's a little balance. I don't know, is there a healthy balance between getting vitamin D from the sun and skin cancer?
Yeah, great question. So, there are many different ways you can get your vitamin D. Of course, the sun is a main source. So what happens is when you walk outside, your skin converts the sun into a form of vitamin D that then gets converted again inside your body so that it can do its job. And so, they say in terms of sun exposure, you actually only need like 10 to 15 minutes of sun exposure a day to get that vitamin D. And really, there are many other ways where you can get your vitamin D without sun exposure, so you can take like the vitamin D supplementation. There's vitamin D often in milk, fortified in our foods. So there's lots of other ways you can get your vitamin D, but I think that's a great question, but you really don't need that much sun to get enough vitamin D.
Ready? When you say life expectancy 5-year is a certain percentage, maybe 20%, does that mean the 20% that didn't make it pass away due to the skin cancer, or could it be a heart attack or a car crash or something like that?
Those are disease-specific numbers, so it means, yes, looking at melanoma, so not heart attacks, not some other kind of cancer or anything like that. It's disease-specific for melanoma.
2 questions. The first question is the different stages, stage 0, stage 1, stage 2 of the melanomas. Do they make bigger, deeper cuts? Say stage 0, which I had, it seemed pretty big. So it could get, or is it deeper or bigger? What is it?
Well, first of all, I want to be clear that there's stages and there's levels. So stages are things like, did it go to the lymph nodes? Is it in my lung? Is it in my brain? And that sort of thing. Levels are more like what I showed, where it's this deep or that deep or this deep or that deep, right? So a level 0 means it's confined to the first layer of skin. That was the first one on that chart that I showed you.
Right.
That's great. We love that. Your chance of that coming back, I mean, there are statistics out there that say it's like you have a 99.75, something like that, 5-year survival rate. I don't even know how they even got anybody to have it back, because it is such a good thing. So it's a really good thing that you had that. In terms of levels, yes. So remember when I said there were either 1 centimeter margins or 2 centimeter margins. 1 centimeter margins are anybody with 1 millimeter or less, and 2 centimeter margins are 1 millimeter and more.
And okay, the second part is, what if they biopsy one and it comes back, the biopsy got all it has clear borders. The doctor said something like, protocol 2 years ago, they would remove that one anyways. Now is different. Can you comment?
Okay, you might be talking about atypical nevi and not melanoma.
Well,
so atypical nevi are, remember that guy we saw with a whole bunch of moles and that sort of thing, and they were all a little bit different? Those are atypical nevi. It was common in the past to re-excise all atypical nevi. Now we know that we don't have to do mild atypical nevi. Moderate, we often don't do as well. If it's moderate to severe or severe, then we'll go back and take a margin. In terms of melanomas, we're still doing margins. There is some work out there of people looking to see if we need to do as much margin as we have in the past. And I have to tell you, when I was first out of residency, what we would do is we'd the melanoma was here, we put a hand on one side and a hand on the other side, and we took that much. And so over the years, it's gone a lot down. So I don't think we see these much anymore, but we used to see, and they went really deep. So you used to see people with a big chunk out of their back, and you could see all their muscles moving and all that kind of stuff, which was kind of a cool anatomy lesson, but thank goodness we don't do that anymore. Yeah.
And just to kind of add with the moles, you know, the moles to melanoma, it's kind of a spectrum where you have totally normal benign moles, you know, and then there's melanoma on the other end. But what Dr. Smith was saying with the atypical nevus is kind of things that are in between, you know. So there are things that are more benign looking that we don't worry about and we can now monitor. And then on the other side, to the grayer side, you know, they look more like melanoma when we look at it under the microscope. And those are the ones that now we still recommend removal. So that spectrum is where there's a little bit of, it can be a little gray.
Cells, and see those cells, those all cells, but it's a lot less, and it had clear margins. We have to justify.
Well, if there's a biopsy, one of the problems is it is not Mohs. With Mohs, you're looking at all the edges. When it's a biopsy, it's like a bread loaf. They just cut it in half and look. So if it's sticking out one side, you don't get that. That's why we go back and do a margin. We want to make sure we've left nothing behind.
You mentioned vitamin D, and I'm just wondering, have any studies been done on a nutritional connection? Are there people that have deficiencies in certain areas that are more likely to get different types of skin cancer?
Probably.
Thank you.
Yeah, I can't tell you I know that granularly, but yes, probably. Anything we should take to help? Well, you should have a normal vitamin D level. Okay, so your doctor should be checking that once a year just to make sure it's normal. Okay.
What about niacide?
Niacinamide? Yeah. So niacinamide is something we give to people to try to keep them from having melanoma. There's another one called HelioCare. Those are pills that you can take to do that. I have to say there was just an article in Nature that showed that niacinamide can actually increase cardiovascular events. So you're going to hear more about that in the news. I was shocked. So anyway, HelioCare for now, and maybe put that niacinamide on the shelf. Maybe it won't be that for melanoma.
I have a question about, I've been hearing about radiation treatment for skin cancer. I know a gal, that wasn't mentioned. Is that the newest thing that type of treatment they're doing?
No, actually, so radiation is a little bit of almost like a last resort for a lot of skin cancer. So generally for basal cell, you know, we just recommend cutting, and same for squamous cell. But there are some instances where, you know, I kind of talked about the treatment would depend if it's very aggressive, you know, and it's affected, you know, some of your nerves and things like that where we can't cleanly cut the whole skin cancer out. Then we would offer radiation, you know, or we have some patients that can't handle surgery for whatever reason, then radiation is also an option. But I would say generally radiation we offer less than some of the ones we talked about.
There is a story behind that, actually. So first of all, in Europe, they use a lot of radiation, right? But they get reimbursed in a different way. So here, they don't want to send to radiation because they're making a lot of money making Mohs, doing Mohs, right? So, and my husband's a Mohs surgeon, so it's not like I'm, whatever. But, so I'm not biased, but anyway, but about 10 years ago now, somebody came out with a machine, and can't remember the name anymore, but a machine for doing superficial radiation for some of these tumors, and a whole lot of people went for it, and I think it did quite well. But what happened was when it first came out, the insurance companies were paying this much for it. When they realized that dermatologists were doing a whole lot of it, they started paying this much, and now we're not doing it anymore. So there's a lot of things going into that. Yeah.
And second part of that question, what about red light or LED light?
Oh.
As a preventative?
Well, again, kind of controversial. You know, maybe there is a little bit of benefit, but it's an expensive machine and that sort of thing. I'd like to see more studies. A lot of the studies were done by the companies that make them, so it's kind of hard to know and ferret out what's going on. I'm still on the fence. How about you?
Same. So I think in terms of skin cancer prevention, the evidence really isn't that great for red light. Some people use it for like hair growth or some other cosmetic reasons, and again, I think a lot of the studies were done by the company, but I would say that the evidence actually for that might be a little better. Yeah.
Okay, go ahead.
Hello. So for my first, I have two questions. So for my first one, are there any emerging tools or treatments for skin cancer that you're excited about? And then two, what role do you see AI playing in skin cancer diagnosis?
Oh, those are great questions. And so the first question in terms of things we're excited about, I think there's a lot more, Dr. Smith was mentioning this blood test. 40 years later, we still don't have a blood test, but we actually do know a lot more in terms of how we're supposed to manage different skin melanomas and skin cancers. So for melanomas, there's been some people looking at certain gene signatures from the biopsy to kind of predict whether it would invade or not, And then even in terms of the immunotherapy treatment front, there's a lot of new and exciting strategies that we're coming out with. So other than just immunotherapy, we can target very specific mutations that we find in your melanoma from the biopsy. And then the hope is that when we combine these things, we can even further improve treatment. And so, I think as we talk about personalized medicine, there's more and more knowledge now that we can actually individually identify mutations for different patients and then target them specifically. Dr. Smith?
I agree.
And then for AI, there's a lot of people looking at AI in different dimensions, in terms of the diagnosis and the treatment, but I think it's still too early. There's a lot of things in progress that hopefully we'll hear more about soon.
This will be our last question.
I was wondering if you have a history of melanoma and then another treatment you receive cryosurgery. Is there a risk that there may be that you may miss a melanoma and do cryosurgery instead of excising it or biopsying it?
Yes, there is a little bit of a risk, but the good news is we've trained for a very long time, and we're pretty good at differentiating them. But you're right. Remember, there was one I showed you that was pink instead of brown. So does it happen? Yes. It's very rare. But there are, with that dermatoscope, changes we see even in the pink ones that say, uh-oh, this one's the bad guy. Yeah.
So that was our last question. Dr. Smith and Dr. Shiu will be up here after our meeting. If you have more questions, you can come up and talk to them. Let me remind you once more to become a member so you can come to our summer solstice. Kunga's in the back of the room. She'd be happy to help you enroll tonight. This is our last meeting of Medicine in Our Backyard for this season. So have a wonderful summer, and we'll see you in the fall.